This is a case of a 26-year-old Mandarin-speaking female with a past medical history of gastroparesis and severe erosive esophagitis, as well as type 1 diabetes mellitus. She presented to the hospital with 1 day of worsening nausea and vomiting and severe epigastric pain associated with constipation. She reported that her last insulin dose was the day prior to admission. She also said that at baseline she had been vomiting every morning for the past month, and that usually improved after eating, but on the day of presentation she had intractable vomiting that didn't improve. She had a hospitalization for the same chief of complaint 1 month prior when she was diagnosed with gastroparesis and esophagitis. At the emergency department, she was found to be tachycardic in the 100s. She was hypertensive with systolic pressures in the 150s. She had diffuse abdominal tenderness to palpation, and she was actively vomiting, non-bilious, non-bloody. Labs upon admission were significant for a venous blood gas with an alkalemic pH of 7.4, PCO2 of 37. Her BNP was significant for a low bicarbonate, an increased anion gap of 23, and glucose of 387. Her urinalysis showed glucosuria, ketonuria. She had an increased beta-hydroxybutyrate and a normal lactic acid. She was initially given hydromorphone, 2 liters of normal saline, Zofran, and 4 units of insulin. She was then transferred to the general medicine service. Upon admission to the floor, the admitting team considered gastroparesis was the leading primary working diagnosis that most likely explained the patient presentation. It was documented that the patient had a high anion gap and increased glucose, but since the patient was not acidotic, she was not currently on DKA. The diagnostic plan was to repeat BMP and consult GI for possible gastric emptying study. Normal saline was continued in addition to metoclopramide, Zofran, and Tylenol. She was given 14 units of long-acting insulin and placed on a standard insulin sliding scale. In this slide, you can see trends over time for glucose on the left and anion gap on the right. On hospital day number 1, she was transitioned to dextrose-containing fluids because she continued vomiting and wasn't tolerating any food intake. On hospital day number 2, she persistently had elevated fingerstick glucose measures. During the 3rd night of hospitalization, she reported to her nurse that she wasn't feeling good. She had a fingerstick of 438 and a Neurofol. The next morning, she persisted to have fingerstick glucose in the mid-400s, despite increasing intensity of insulin sliding scale. She had persistent abdominal pain and the endocrinology was consulted. At that time, they considered the patient was in DKA, and then she was transferred to the ICU for insulin drip and aggressive hydration. After a couple of hours, her metabolic derangements improved, her symptoms resolved, and she started to tolerate oral intake. This is an example of a case with diagnostic error in the inpatient setting. The diagnosis of DKA was missed at the time of admission and during the first 3 days of hospitalization. First, upon admission, this patient did meet criteria for mild DKA. However, the acid-base status was incorrectly interpreted as normal because of a pH of 7.4 on VBG. The delta-delta ratio was 1.96, which is indicative of a mixed primary metabolic acidosis from ketones and concurrent metabolic alkalosis from gastric losses due to her intractable vomiting. The source of error was not doing a holistic interpretation of blood gases and concurrent metabolic derangements with a history of present illness. Also, the admitting team most likely anchored on the same diagnosis as the recent hospitalization because the clinical presentation was similar. However, on that previous hospitalization, the patient didn't have any metabolic derangements. We recommend using a delta-delta ratio for the interpretation of acid-base status when there is suspicion of a mixed metabolic acidosis and metabolic alkalosis. We also suggest to perform a diagnostic timeout upon admission to the floor. Identify what doesn't fit with the working diagnosis. Discuss alternative diagnosis. Obtain additional history, and communicate diagnostic uncertainty to other members of the team and to the patient.